days, but now you're here and the sky is clear. You're the one who always treats me right. You're the one who takes care of me. I've been lifted up by you. 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 Your love surrounds me like a cozy cloud. You make me happy and I shout it out. There's no one else out there to compete with you. No, there will never be a friend like you. I've been lifted up by 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 you.
Our wonderful doctors up on the camera. All right, there are our doctors, Dr. John, Dr. Kelly. Welcome to MG Wellness Ask a Doctor. And tonight we're going to be talking about cancer and genetics. But let's start with a little bit of housekeeping. So let's make sure you know how you can send questions to us. Best way, those of you who are watching right now and you're live on YouTube, you're live on Facebook, you can go right into the chat section. We'll be able to see that right there, and you can ask questions. We've already had several people ask questions through those comment groups. You can also email us at support@mgwellness.org. And so we're going to be watching those live right here. And so please be asking questions throughout. I want to also say that you can go to mgwellnessnewsletter.com and be on our email list. You can make sure that you know the most up-to-date information anytime that we're doing live Ask a Doctors. We have lots of lives scheduled here right after the holiday, after Thanksgiving. We have several things that are going on, including the launch of our new course, which we'll be talking about here just a little bit later. So as we bring Dr. John and Dr. Kelly back up on the camera here, let me unclick and take our wonderful picture of fresh blueberries and MG Wellness down. And let me take the countdown down as well. Dr. John, Dr. Kelly, can you tell us in 30 seconds or less what you knew about cancer and genetics when you were in college?
Wow. That's a long, long time ago.
Pretty much nothing, because
Right.
the genes that we're talking about weren't even discovered.
Yeah. We didn't think the same way about cancer and genetics as we do now. And to be honest, probably in 20 years, it'll be completely different from what we think now.
The only thing we learned in biology was Al Knudsen and the two-hit hypothesis on retinoblastoma.
Yes. So we knew very little of what we know now in college. We're experiencing just a little bit of technical issues, but I think we're getting them resolved.
We are getting there. Just a second, guys. We're going to switch the microphone power. So you've been hearing us through a laptop microphone instead of the actual microphone because the power just died to the actual microphones. So give us a second. I'm going to just take a second and bring up our mgnewsletter.com where you can sign up for our MG newsletter. We'll get to your questions here in just a second. If you can give me 30 seconds to figure out why I don't have any power on our switcher. All right.
This is it.
All right, test 1, 2, 3, 4. I think we have power back. We're going to do a little bit of live mic check as we are live. That's why you do live, right? So let me bring up Dr. John, Dr. Kelly again. We'll start over all the way from scratch. Thank you for those who stayed with us and didn't leave. All right, there's Dr. John, Dr. Kelly. And let me get my microphone on. All right. I hear myself. Let's hear Dr. John, Dr. Kelly. You guys talking to your microphones. Say hello.
Hello, how are you?
Hello. Hello, hello.
All right. I think everybody hears everyone. I apologize for that. We just lost power to our little microphones. All right, we're going to start again, and we're going to talk about what is genetics, are genetics, and what is the study of hereditary medicine and a variety of other things as I get my list of beginning questions. So let's start with the very basics, the smallest part that we can start when talking about genetics. What is a gene? I'm going to guess that Dr. John is the one who's going to answer this.
So I will say something, and then my lovely wife will probably translate it. Basically, a gene, and I'm not talking about these, a gene, G-E-N-E, is a sequence of DNA that creates a protein, and that is the smallest inheritable sequence that we have.
Genes are what make us who we are. So that's what makes us individuals. What makes us different from one another are inherited genes from our parents. And so that was the translation of the smallest inherited DNA material.
DNA sequence, thank you.
Yes.
I could have gotten into the...
Oh, he can tell you a lot more.
All right, so we got the basics. And we have sound, and I thank you, Scott and Bonnie and Sean and others who are telling me that we have audio. And I appreciate you hanging in there and staying on. I know for a second we were just a little bit quiet. But let's talk about, we talk about genes, but then we use the phrase hereditary, or the word hereditary, and we will say cancers are hereditary or diseases are hereditary. What in the world does hereditary mean?
So I will say something and Kelly will translate it again. Basically, hereditary means that it is able to be inherited from one of your parents.
Yes, and that's easy to understand. The difference that we want to call out is that many, many things have been found scientifically to possibly be inherited. But what's really important to understand is that a lot of things that are thought to be inherited are really just because we grew up with certain habits, eating habits, exercise habits, environmental habits, whether it's eating processed foods or eating food from the garden, whole foods, or exercising or not exercising, or smoking or not smoking. So a lot of times things are said to be passed along, inherited, but really they may just come from the homes or the families in which we were raised. Now, there are other things that we're going to talk about tonight that are truly inherited.
But as we've talked about over the last several weeks, the vast majority of cancers are lifestyle cancers,
Yes.
not inherited cancers.
And inherited cancers are really from specific, very specific gene, Gene, defects that are passed along from your father or from your mother that then increase your risk for cancer.
Right.
Now, those gene defects don't necessarily mean you're going to get cancer.
No, but I'm sure someone will ask that later.
Yes,
It just
Correct.
increases your risk.
correct.
All right, let's keep going with our regular questions that we kind of set up. Several of these were asked beforehand. Some we were just gives us a good foundation. So, as we're going to bridge into hereditary cancer, we always like to, in case somebody's new, give a definition of what is cancer, since that is the basis of hereditary cancer.
So, cancer is an abnormal cell from within your own body. It's a cell that has obtained several special abilities. One is the ability to invade the tissue around it. The second one is the ability to spread or metastasize. The third ability that it's gained is immortality. Cells have a program, should have a program, cell death in them, but cancer cells lose that and just keep going on, or they're immortal. Anything else?
The fourth is that even after a patient with cancer, and this is in very advanced stages of cancer, even after a patient may not feel the desire to eat or to drink anymore, the cancer cells obtain the ability to still live.
Right. They can keep going by basically parasitically using the proteins in the body to
live.
continue.
Right. So that's what cancer really is by definition.
Perfect. And then, so let's talk about hereditary cancer, and then we'll get into some things like genetic counseling. Let's start with hereditary cancers. Which cancers do we know are hereditary, or what does it even mean to be a hereditary cancer?
Go ahead.
So hereditary cancer is a cancer that can be passed along. And it's not even necessarily a specific cancer, but it can be a syndrome involving multiple cancers. And the way you identify something like that is early onset age, or early age of when someone gets cancer, having a cancer in multiple family members, and especially multiple family members across multiple generations. That's when it looks like something that is a hereditary cancer.
Correct. One of the things that we routinely ask when we are talking to patients about the potential for hereditary cancers is that early onset of age of cancer. So, if somebody is 20 or 30 in the family and has a very unusual cancer for that age, that raises the suspicion for hereditary cancer.
All right. I always want to confirm. Several people are saying we're getting audio. If you are not getting audio, you may want to check that you may not have your volume turned up. I think every place, to our knowledge, volume is up and working now. As we're going into the hereditary cancers, let's talk a little bit about what are because I see some of the questions here that we have. What are the two most common hereditary cancers? And then we'll get on to even talking about common hereditary syndromes. But let's start with hereditary cancers.
So the two most common, if you look, basically it's because they're two of the most common cancers in general, are breast cancer and colorectal cancer. Those are the two most likely, the most commonly found as a hereditary cancer.
And those are not necessarily in the same syndromes,
Correct.
right? Which we'll talk about in a second. But those are the most commonly associated with hereditary genes that have defects.
Not blue genes.
Not blue genes, doctor.
Okay, not blue
Like
genes.
Stonewashed,
Nice. You're out of date, honey.
so. Shocking.
Well, stonewashed jeans, those classic
coming back
Levi's.
in?
I don't know, but there is a huge, like on what's the Poshmark? You can get a lot of vintage.
Poshmark.
Yes.
By vintage, we
Levi's.
mean old.
Which means like half my closet.
So,
Nice.
all right. So I've lost track where we are, but I don't think we've answered the question. What are some common hereditary syndromes yet?
The two most common hereditary syndromes, and I'll even not give the genes involved so I don't go too deep into
Please
the
do
weeds,
not.
are hereditary breast and ovarian cancer syndrome and what is called Lynch syndrome.
Yes. So hereditary breast and ovarian cancer syndrome, obviously,
Are
breast and ovary.
Huh.
Yeah. But Lynch
That's why it's called
syndrome is the colorectal cancer syndrome. But
But why
what's
is it
the
called-
thing that you always like to talk about because we are GYN oncologists?
Well, one of the reason why it's called Lynch syndrome now, when it used to be called hereditary non-polyposis colon cancer, HNPCC, is that the most common cancer to show up first in women is actually endometrial cancer, a type of uterine cancer. And so it didn't really make sense to call it hereditary non-polyposis colon cancer, when in women, the most common thing is uterine cancer. So the name was changed to honor Henry Lynch, who actually just passed away a few months ago. I had the honor to meet him at one of my visits out to his old university. And in his 90s, he still came in every day into his lab.
Did a lot of incredible.
Unbelievable dedication. Not sure about the family life, but unbelievable dedication to medicine and to helping people.
All right, we're going to take just a second to take a quick pause because it's always good to remind people. We have a couple questions here in chat that I'm about to bring up. But to remind you that if you ask a question in the comments here on Facebook or YouTube, we can certainly bring those up on screen. Make sure Dr. John and Dr. Kelly are answering those. We are also monitoring our email at support@mgwellness.org. And what we would also ask you to do right now, if you're watching this on Facebook or you're watching this on YouTube, if you can click the share button and share it to your timeline, if you can share the live feed or you can share this afterwards. Tonight specifically, we will also be posting a clean, since we had a little air there at the beginning, we'll post a clean feed without the opening for a couple minutes. So we'll be doing that probably later this evening. But we would love it if you'd share. And if you are new to MG Wellness, which I see a couple new names I've seen already pop up that are watching, you can make sure you're on our email list at mgwellnessnewsletter.com. That's mgwellnessnewsletter.com. You just put your email in there, click submit, and you will be on our email newsletter. We have a great issue coming out next Tuesday where we're going to be talking about all kinds of things that are coming up, and we would love it if you were part of this and making sure that you're up to date. So as we come back to a couple of these questions, let me pull up the questions from Let's start here. We'll start here. Sean asked, what is low-grade cancer exactly? I know that is something that we're going to be talking as a question on later on our list, but since it was one of the first ones brought up, what is low-grade cancer?
So when you look at cancers, most people think about stage, and stage is how far it's spread. But grade is how it looks under the microscope. The less normal looking, the more mitotic figures, if I can,
Higher grade.
is the higher grade. So a low grade cancer looks more like the normal tissue that it came from. For instance, a low grade ovarian cancer still shows areas that look like
Normal.
And the big thing about low grade versus high grade is that low grade has a tendency to be much slower growing, and at the same time, and part of the reason why is that it has fewer mutations in genes throughout the cancer. You may hear me throw a couple terms out that are important in this, and there's no test. Kelly wouldn't let me put out a quiz. But the two are germline and somatic. Germline means that it is able to be inherited. The germ cells are the sperm and eggs, and those can carry the mutation and pass it down to a child. Those are germline mutations or inherited mutations or hereditary cancers, things like that. Somatic, which comes from the Greek soma, which is body, means that it happened in your own body. It cannot be inherited. So most low-grade cancers have a much lower rate of somatic mutations.
So,
Translated as,
no, what I'm going to reiterate is that grade, just like Dr. John said, has to do with how organized or disorganized the cancer cells look underneath the microscope. So low grade means that the cancer cells look very organized. They play nicely with each other. They all tend to look the same. They line up well. And higher grade means that the cancer cells look different from each other. Some are light, some are dark, some are big, some are small.
they run with scissors.
Yes, they look, and they fight with each other underneath the microscope. If I can
Okay.
actually give them personality.
I'm sure she's not listening today, but you actually just reminded me so much of one of our pathologists from the university
Yes.
who used to always talk about, that was how she would describe the cells to our residents and students when we would get together for PATH conference, about how well they played together.
Yes. So that's the difference between low grade and high grade. Low grade are very organized and they tend to behave a little bit better than high grade. So that's the answer to that. I think we are still working on our technical issues.
We are. We're still having a couple issues. I may switch out microphones here in a second. We're having a problem with Dr. Kelly's microphone, but they're hearing you. It's just being picked up off of Dr. John's microphone. So
Okay.
don't try to play with it. Just go with it. I'm going to see if I can fix it one more time here.
Okay.
But I'm going to bring up another question. Sean asked after that. Asked, is melanoma genetic? If so, is there any blood test to test for melanoma?
It can be genetic or it can be in a hereditary cancer. The way to figure out is what age did someone get melanoma at, how many relatives have melanoma, and has it occurred in multiple generations. So looking at that, you have to answer those questions and then decide. There are two different syndromes that can involve melanoma. The one that we'll talk about first is appropriately named hereditary breast and ovarian cancer. Yes, I'm serious. Melanoma actually runs in that syndrome. At the same time, there is a syndrome that doesn't really have a name, but there's a genetic defect in a gene called P16. See, I got to say the name of a gene without.
Yes, I know you're very excited.
I am excited. And P16 is just basically melanomas. And those tests can be done off of blood, and they can also be done off of buccal samples.
That's the mouth.
Thank you.
That's what buccal means.
Not belt buckle, yeah. Okay, good point.
It's buccal, Buccal, and that means from the inside of the mouth. So it's just a swab, usually of the inside of the mouth.
You can guess that she was the spelling bee champion.
Yes, I was. How are we doing? Can we hear me yet?
You can hear everything you say, Dr. Kelly. It's just a little bit quieter, so everybody's
No.
having to work a little bit harder to listen to you. But let's we're slowly getting that fixed up. And Dr. John, you can move your microphone back to you.
I was
And
trying to
so
share when
I know you guys are doing a great job.
I'm usually accused of not sharing well enough and running with scissors.
All right, so stop listening to the replay, which is about 15 seconds behind, which is always a little bit distracting. So let's talk about the RA, rheumatoid arthritis, and there's some questions before we started tonight
Yes.
about rheumatoid arthritis, and is that hereditary?
So, Dr. Kelly kind of brought this up earlier. Rheumatoid arthritis has not been linked to a single gene that is inherited. However, it looks like it because often rheumatoid arthritis will run in families.
Right.
But the reason it runs in families is because of inflammatory foods, inflammatory environment, and destruction of the gut microbiome.
Right. So it appears that rheumatoid arthritis is more associated with environmental things. I don't mean by chemicals, but what I mean is the homes in which someone was raised,
The food at which you eat, the water you drink.
the exercise you do or do not do.
Right.
So it's more associated with those kinds of things and less associated with specific inherited genes.
Right.
Why do you think things like that start? That things are hereditary? Because a lot of times we just see everything as hereditary. Why is it? Just because we want to have someone to blame for it, or was this something that when we were first trying to figure out what was hereditary and not, we just made some misdiagnoses? Why are so many things seen to be hereditary when they're probably not hereditary?
So I'm going to start with that one.
She'll
This
give a
is-
PC answer. I'll give
No, this is something that I think is really, really important to understand in the scientific data that is available. So when we look back at scientific studies, really until the 1990s, the science was relatively weak.
I was going to say really and almost to the late 90s,
Right.
early 2000s.
And it wasn't until the 1990s that we started to look at how we were collecting data, how we were doing scientific studies, and the biases and the
Statistical analysis.
Right.
If you look at the statistical analysis of studies done,
it was very weak.
I mean, that type of statistics I could actually do in my head.
Right.
With modern statistics,
It's very complicated. But the point that I was going to make is a lot of studies that were done many, many years ago, and there are still many of these studies done now, are epidemiologic studies. Big word. What it means is that sometimes we can draw conclusions that are really not accurate by saying that, oh, we found that diabetes may be hereditary. If you have a family history of diabetes, you have a higher likelihood of having diabetes. Well, is there a specific gene, or are there a set of genes that are associated with that? Or is it really because
the
you
way
may
you're
have been
raised.
raised in a family where consumption of certain foods was more common, and you developed certain habits of exercise or not exercise.
Yeah, and Kelly always makes fun of me for this, but to give an example that's really out there, but it'll get the point across, is I can definitively tell you epidemiologically that everyone who's died has breathed air.
Right.
And
Clearly.
but
That's a problem.
But breathing air does not cause you to die. So just because something's associated epidemiologically does not mean there's a cause and effect at all.
Right.
And so that's where those things come from, is that epidemiologic studies link something, but there's no true cause and effect.
Right. And it's not that epidemiologic studies are bad. They tell us kind of where we need to look further. That's really what
They're
they
the
do.
start point.
Right. That's where we start. It's a starting point, but it is just a starting point, and we have to say, okay, is there a causal relationship or is it just a correlation? So,
Right. And those are two completely different things.
right.
All right, let's talk about genetic counseling. Let's start with what is genetic counseling?
So genetic counseling, basically the way to look at it and understand it quickly is genetic counseling is a risk assessment or risk evaluation. That is exactly what it is.
Right. So it's talking to someone. It may be somebody who has a master's in genetics or a PhD in genetics, or a physician
Who's trained in it.
who's trained in doing genetic counseling. And genetic counseling often involves just having a conversation with somebody to say, okay, let's draw a picture of your family tree and let's talk about who had cancer, how old they were when they were diagnosed, and what their outcome was.
That's called a pedigree analysis.
That is correct. And that's where it starts. And then from that, a risk assessment is formed.
Right. And then from that, the decision whether or not to do genetic testing is done.
And genetic testing is either blood work, or it can come from the swab in the mouth, which is called the buccal mucosa, that can determine the DNA in the cells that are collected, whether it's blood, whether it's oral swab, can determine if you have, or someone that you love has, a inherited genetic mutation.
Correct.
So that's what genetic counseling involves.
All right, so who should get genetic counseling? Should everyone be part of that?
At this point, no. Though there's a move to have everybody get their whole genome sequenced.
Well, what have you and your brother done?
Well, but that wasn't getting it sequenced.
No,
that was
it's
just
not, but it
that was
is-
Ancestry.com. So, by the way, Ancestry.com and 23andMe do not tell you about genetic cancers. They look for a couple, but only if you're Ashkenazi Jew, which my brother and I both are. But it only looks for those very specific ones. If you do that and it doesn't show anything, it does not mean you do not have a genetic cancer.
But it can tell you if you're lactose intolerant.
And if you have brown hair and a chance of balding.
Some things just didn't surprise us. So
who should get
who should
genetic
get who should get it?
So people who have, if you have yourself a cancer at a young age, less than 40, less than 50, and we're going to talk about this from the point of view of you having the cancer, or what we call the proband, and then we'll talk about it otherwise. So if you have a cancer at an early age, or say you had breast cancer and you're 55, it's not young, but your mom had breast cancer, that's a close relative, and your mom's aunt had breast cancer, that's 3 generations. So if you have cancer at a young age, if you have multiple generations, you have multiple family members with either the same cancer or cancer that fit in the same syndrome, then that is the people that should get tested. Or talking from the point of view of someone who doesn't have cancer, if someone in your family has an early cancer, below 40 or 50, depending on the cancer. If you have multiple generations involved with cancers that fit into a syndrome or the same cancer, or if you have multiple first degree or second degree relatives that have cancer. Translated as?
So, first degree relatives would include those immediately around you. That does not include aunts, uncles. That includes sibs, parents.
And children.
Yes, and children. So that's first degree relatives. Then secondary expands from that. The other
Which is
two,
the aunts and the uncles.
right. The other two things I wanted to point out is if there is someone in the family, if you or someone in the family has more than one type of cancer
Right.
within that single person, that's important to know in the family history.
Absolutely.
And then the other thing is for organs that come in pairs, breast, kidney, eyes, if one person has had the cancer
In both.
sides, then that is also important in terms of whether or not you should have genetic counseling.
Correct.
So those are the things that really determine if you should talk to somebody about your pedigree or family history.
Right.
So let's think a little bit. Obviously, things have rapidly changed when it comes to the study of genetics. Things have, in the last quarter of a century, have come a long way. What will things look like? Let's future cast. Obviously, we're not going to be held to this, but what are some of the things and what are some of the possibilities that could happen in the next decade?
So, if you look back 20 years ago, we thought there was going to be BRCA1, BRCA2, and BRCA3 for hereditary breast and ovarian cancer syndrome. In fact, we tried multiple times to find BRCA3. I spent a lot of time looking at that. What it turns out is that rather than BRCA3, we actually have about 10 or 15 other genes that make up that other small part. So we're going to find more genes that are related to cancers where we don't specifically have just one defect. A syndrome called Li-Fraumeni syndrome, which is a syndrome in which people get cancers at pretty young age, and it was all thought to be from a gene called P53, which is the most common tumor suppressor gene defect in cancers, has now been shown that it can actually be in other genes too. So we're going to find more genes, and we are going to find more drugs that specifically target gene defects. And I don't know if we're going to go back to what we tried to do previously, which is repairs.
Well, and there are lots and lots of scientific articles that are out there about CRISPR, things like that are exciting things on the horizon, we think, kind of scary, that may be able to modify or correct genetic mutations. We just don't know a lot about it yet, and trials are ongoing. But certainly there is a lot going on in the world of genetic engineering of sorts.
Yes.
Yes.
So Bonnie asks, my sister had ovarian cancer, but no one before her. Do I need to get genetic counseling for myself and my two daughters?
How old was your sister? And what type of ovarian cancer?
Right. If she was young and she had what is called an epithelial ovarian cancer, was she genetically tested? She should be. Anybody with ovarian cancer.
Anybody with epithelial ovarian cancer should be genetically tested. And it's been that way for the last 10 years, roughly. Right. And so she should have been tested. Unfortunately, it only works out to about 15% actually get it done, even though 100% should. It's the difficulty for you, Bonnie, is whether or not insurance will pay for it. And it's expensive.
Sometimes they do, and sometimes they don't. And if you can get your physician to fight hard for that, if your sister was not genetically tested, because it can help you to determine what you need to do to protect yourself. It's just really important that every woman who has ovarian cancer of the epithelial variety
Gets tested.
gets genetically tested.
Because this is the issue that we know. If your sister wasn't tested or was tested in the distant past before we had what's called cascade testing, and she was only tested for BRCA1 and BRCA2 and not the rest of them. So cascade means you're tested for BRCA1, BRCA2 throughout the whole those two genes, and if it's not present in those, you go through the rest of the genes. If she only had BRCA1 or BRCA2 and was negative, did not have those mutations, then even if you get tested and you're negative, we don't have an answer still.
Right. If your sister wasn't fully tested for all of those 15 different genetic defects, then her testing may not be complete.
And so even if you're negative, it does not mean that even if you don't have the defect in one of those genes, it doesn't mean that you aren't at risk. And so the big thing is we always recommend that the person with the cancer gets tested first.
Yes, because then they can narrow down what they're testing in you. So it's a long roundabout way to say we hope she was tested. If she wasn't, see if you can find a doctor who understands all of that jazz and can get you tested.
And Bonnie updated, said she was tested, but not sure about the testing, so she can certainly find out, and that her sister was 50. So,
Yes. So
Yeah.
what, 50, there's no
But it's still ovary.
age. Right. There's no age criteria. There's an age criteria for breast cancer, less
colon.
than 50, and colon. But with ovary cancer, it doesn't really matter as much the age as it does the completeness of her testing. And if you find
right.
out the completeness of her testing and when that was done, you can message us and we can try to answer that specifically for you.
All right. We'll go back. Just a reminder, we have about 15 minutes left where we'll be live, but you can ask a question here in the comments in Facebook, where most of you are. And then I see several now over on our YouTube channel, and we thank you for joining us here. You can make comments there, either of those places. You can email us at support@mgwellness.org. And then we also please encourage you to go to mgwellnessnewsletter.com, where you can sign up to be on our email newsletter. Make sure that you're receiving all the newest information from MG Wellness, as we provide lots of free content. I also encourage you, please follow the Facebook page. A lot of you, if you're out watching on Facebook, I think you can just click the icon there for MG Wellness. Make sure that you've liked that page, as well as you can go follow on Instagram, MG Wellness 1. That's the number 1. And you just search MG Wellness, you'll find us. As well, one other thing, you can subscribe on Facebook, or excuse me, on YouTube, and we encourage you to get those notifications. Hit that bell so that every time we post new video, we posted a few new ones this past week. I think this will be our 3rd video with the live going in there, and we have a few more left to go in there in the next couple of weeks as we head into the holiday season and head into our first course launch the first week of December. As we bring back Dr. Kelly and Dr. John, I'm going to ask them to remind us a little bit of who is MG Wellness and a little bit about our mission as we've launched MG Wellness the last couple months.
So MG Wellness came about just a few months ago. It really came about because Dr. John and I went through kind of a health revolution of sorts personally. And through that, we came to see how much need there was for us as physicians to use the things that we have learned to get more information to more people, to come alongside people and help them determine what is best for their health.
And one of the things that we've seen, and there's lots of data showing this, that people go to the internet to look for information, and the information is very confusing. Some of it is confusing because of the studies. Some of it's confusing because of the interpretation of the studies. And understand that the medical literature is doubling every 3 years. And so coming alongside you and helping you with this information means sifting through this information to give you what's vital for your health.
Right. So that you can make changes that don't require getting on yet another medication, but perhaps making lifestyle changes or decisions about genetic counseling or something else that we talk about that can help you reduce your risk of having any of a variety of illnesses, keeping you off of medications, keeping you out of the hospital. That's really the goal, is to spread that type of health and wellness.
And along with the question from our producer, Nate Manahan, and along with what Dr. Kelly said, something that's very important to remember is just because you have a genetic mutation that puts you at risk for cancer does not mean you're going to get the cancer. And there are things you can do surgically, medicinally, and with your diet and exercise to reduce your risks.
Right. Not everybody that inherits this type of genetic mutation, not everybody will get a cancer. And so you have to arm yourself with information that is reliable and trustworthy to be able to know how you can reduce your risk personally.
All right. So, we have about a couple more minutes if you have any more questions. I know we had a question come in earlier talking about soy and breast cancer. And I'm just going to put those two things together and let you kind of go from there.
So this is one of my favorite ones.
And this is a question that we get all the time. All the time.
That is another one where it was a kind of a mistake by the medical literature and by people interpreting information that was wrong. Just because something's called a phytoestrogen does not mean that it is an estrogen in humans. In fact, soy phytoestrogens basically block the estrogen receptors in humans. And so
they act like an anti-estrogen.
Right. Soy actually is preventative of breast cancer. Believe it or not, there's tons of data now. And yes, I know there are still doctors out there that tell you, oh no, you're at risk for breast cancer. Or, oh no, you've had breast cancer. You can't eat soy. They're wrong. That data has been disproven for years.
And the comment that was made on the event, she actually said that her doctor did recommend soy. And so we absolutely 100% agree with that. Your doctor's right. And that's valuable information to have, that you can trust what that doctor is saying. That is correct. Soy is absolutely important for those who've had breast cancer, for those at risk for breast cancer. I have my soy multiple times every week.
Yes, I make sure that she gets her soy along with white button mushrooms.
Yes, they both decrease the risk of breast cancer.
So what are the general things that anyone should do if you don't know if you don't know anything about anyone's family history? What are some things which, when it comes to genetics, that they may do? What should their response be to this kind of conversation?
So I'm sure we're going to talk about, you and I will talk about different things because we always hit on different topics. My first one is walking at least 30 minutes, 5 days a week. Just exercising actually decreases your risk of developing cancer.
And my big mantra is removing processed foods from your diet. We hammer on this all the time, and I hope that we hammer on it from now until whenever, because processed foods have been destroying us in the United States, absolutely destroying us. Chronic lifestyle diseases have taken over this country.
And cancer is one of those.
And cancer is one of those,
And we're not harping on it to blame anyone, but to actually empower you to know that your cancer probably came from that. So if you have cancer, get rid of those processed food, get rid of high fructose corn syrup, get rid of cornstarch, get rid of anything with eights and ites and eats and
Yes. As we prepare for the big feast next week, a week from tomorrow, I'll tell you what, if we took this opportunity to secretly and sneakily create healthy versions of things that we love, and healthy does not mean taste bad. That's something that we've got to get over. If we make healthy versions of those things, we are contributing to A, the enjoyment of Thanksgiving, and B, the health of all those people around the table. So,
if you decide to get rid of the processed foods, as an adult especially, you will notice very quickly, one, you have to withdraw from them.
yes,
And two, that if you go back to eating them again, you'll feel like crap the next day,
right.
which is the way you felt beforehand.
We had a friend reach out to us just today and state that last week she had some relatives in town and
She's been eating healthy for several months.
right, and she had been feeling great. But she had relatives in town and they went out to eat and they kind of, celebrated by having whatever. And she felt terrible immediately and kind of returned to that way she had been feeling before. And so it's just another example of the fact that if we remove processed foods from our diet, we can actually feel better and reduce our risk of chronic lifestyle diseases.
Including cancer. And
Right.
And so those are the biggest things you can do: exercise and diet.
Right.
So when it comes to our genes, as we kind of wrap up, and this will be our last call for questions. If you have any, you can put them in our comments section here. As it comes to our genes, who should be at the highest, alert because of who should be listening, going to see a doctor, going to get genetic counseling? Who's the ones that should be most alert of what's going on with their genetics?
If you had cancer at a young age, breast or colon cancer below 50, if you've had ovarian cancer, or if you had as Dr. Kelly said, a paired cancer.
Right. Or multiple family members who
In
have
multiple
had,
generations.
Right. In multiple generations who have had cancers. We know that you're not going to know all the specific cancers that are associated in syndromes, but
You
if
don't
you
need to.
have an extensive family history of cancers, then talk to somebody about the potential for needing genetic counseling, because that's something that can be ironed out through a family tree pedigree to determine if you need genetic testing.
All right. Well, I want to thank you everyone for joining us this evening. Thank you so much for being part of tonight's Ask a Doctor. And we're going to finish with two different questions. One, let's start with what is the first course that MG Wellness is launching?
So we're really excited that just in a couple of weeks, we are going to be launching our first course, which is entitled How to Live My Best Life on Chemo. We know that there are so many, many precious patients who are suffering through chemotherapy. And what we would love to be able to do is, through this course, and we believe that we can, bring help, hope, and healing to those who are undergoing chemotherapy and even to caregivers.
That was awesome alliteration.
It was outstanding. Let me say that again. Help, hope, and healing. I didn't even practice that beforehand, but we believe that through this course, we can provide help to those who are undergoing chemotherapy. One of the frustrations that we have encountered repeatedly throughout our careers is seeing patients who have suffered through chemotherapy who did not have the advice, the counseling from a medical professional,
The education
to help them not to suffer so
And
massively.
Having been in situations where we were often the second opinion, third opinion, even fourth opinion, that was one of the most frustrating things, is to see people not getting the information so that they didn't have to suffer. And so health, hope, and healing, right?
Yes.
Yeah. To break it down, and I get to actually break it down to a smaller. We want people to have more good days on chemo.
Yes, that's the goal of the course. And so,
And you can have them.
yes, it is absolutely possible. There's lots and lots of information included in the course. It comes in 6 modules, and within each module, there are different lessons. So it's broken up into chewable bites of information that can be very, very helpful to you or to someone that you love and care about who's undergoing chemotherapy.
And just because it's Thanksgiving week next week doesn't mean there won't be an Ask a Doctor. In fact, a week from tonight, there will be another Ask a Doctor where we talk about cancer and environmental truth. How does cancer and the environment go together? So as families join together and join us live next week as they pour their fresh glass of water with their sprig of mint and maybe a fresh squeeze of lime or lemon, what will we be talking about, Dr. John and Dr. Kelly?
We will not be talking about turkeys and pumpkin pie causing cancer. No, we're going to talk a lot about in the environment. And this time, we're talking truly about the environment, the water we drink, the air
The
we breathe.
factories that are around us.
And, we're going to talk about everything from heavy metal poisoning to ETO for people out in the audience.
Yes. Lots and lots of things that we are surrounded by every day. Many times we don't even know it. Sometimes we do because of work environment. But sometimes there are things that we're breathing in our air that we don't even know about. We need to become conscious about that. And we have some people who join us weekly who are very, very much in the fight against environmental poisons. And so we want to spread that word and talk more about that, how you can get involved and help yourself.
To give just 2 little tidbits, and this gets into food a little bit, but how many of you knew that ranitidine, Zantac, actually, when it's broken down in your body, actually forms a carcinogen in your body?
Right.
And how many of you knew that Pepsi actually has a carcinogen in it that's been known for years?
Right. So these are things that we'll be talking about. You can ask all of your questions ahead of time or during the live event to talk about environmental risks and cancer.
One thing I did want to bring up that I didn't point out well enough, I don't think, when I was making some comments. When we're talking about hereditary cancers, none of the ones we know at this point are on the X chromosome, meaning that it comes from either mom or dad's side. Dr. Kelly said that several times, but I know I didn't point it out enough when I said it because I made a comment about breast cancer and mom. Well, you have to look at dad's side too.
Right.
So either side of the family.
Right. Correct. It doesn't mean when it's inherited that it comes from only one side.
It
Both
can come from
sides
either.
are important.
See, both parents are important.
There we go.
Yay.
Well, thank you very much for joining us tonight. Thank you for spending some of your Wednesday. If you're watching this on demand later, thank you so much. And we will be back 1 week from tonight, 8 o'clock Eastern Time, Facebook Live, YouTube Live for Ask a Doctor. Thank you for joining us. And on that, have a good night.
Bye, folks.